Welcome to the FQHC RHC Telehealth Billing and Coding Beyond the Basics webinar. My name is Christina Quinlan, Telehealth RCM Strategist for the Northeast Telehealth Resource Center, or for short, NETRIC. The Northeast Telehealth Resource Center is a federally funded cooperative agreement effort through the Health Resource and Service Administration, also known as HRSA, and the Office for Advancement of Telehealth. NETRIC is a collaborative effort staffed by team members at MCD Global Health, a global nonprofit in the University of Vermont. NETRIC serves New England and New York and is a proud member of the National Consortium of Telehealth Resource Centers. We provide technical assistance, including no-cost resources, aimed to increase access to quality healthcare services for rural and medically underserved populations through telehealth. The North Country Telehealth Partnership, a joint venture of Adirondack Health Institute and Fort Drum Regional Health Planning Organization, is Northern New York's leading agency focused on increasing access to healthcare through the innovative use of telehealth and telemedicine technology. The partnership is funded through a Rural Health Network grant through the New York State Department of Health. The ARHN and NCTP programs have worked together to support the creation of this presentation. Funding for this presentation was made possible by the Adirondack Rural Health Network through New York State's Charles D. Cook Office of Rural Health Network Development Program. AHI nor NETRIC have no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services discussed in this webinar. Any information provided today is not to be regarded as legal advice. So let's begin today's webinar. During this webinar, we're going to talk about telehealth policy and licensing, telehealth documentation, specific FQHC and RHC billing for private payer and Medicare and Medicaid, FQHC RHC reimbursement for telehealth, communication, technology-based services, and then we'll go a little bit beyond the basics. There are two actually, resource pages at the end, one that's telehealth generalized, and then the other specific to RHC and FQHC for both Medicare and New York State Medicaid. Policy first, right? What does the policy say? I start with policy because telehealth regulatory guidelines are embedded in federal, state, and payer policies. The public health emergency has been extended to July 15th of 2022, which means that all CMS waivers and telehealth billing and reimbursement will be in place until 12/31/2022, or the end of the year of which the public health emergency ends. Additional flexibility has been extended through the end of 2023, and FQHCs and RHCs are able to furnish all telehealth services during the public health emergency that's listed in CMS's spreadsheet of allowed telehealth services. It will take an act of Congress for telehealth services to be furnished by RHCs and FQHCs beyond the public health emergencies as distant site providers, with the exception of mental health and substance use disorder services. For New York State, audio-only telehealth is included in the state's definition of telehealth and telemedicine. Even post the public health emergency, FQHCs and RHCs may provide distant site services. A distant site is any site within the US or US territories, and New York State waivers, including visiting nurse services. Legislation has been introduced to join the Interstate Medical Licensure Compact. And for more information, I've provided the regulatory guidelines for both New York State insurance law and New York State public law throughout this presentation. Next, we're going to talk about telehealth licensing. Unless New York legislation changes, the following licensing regulatory guidelines are currently in place beyond the public health emergency. Ensure that you're providing services in accordance with your state laws and regulations. And as part of the emergency declarations, many governors have relaxed state laws and regulations related to the provision of telehealth services. For up-to-date information in your state, please contact your state Department of Licensing or state medical association. It's important to remember that telehealth is not a service, but a mode of delivery, and all services within a practitioner's scope of practice is allowed to be delivered via telehealth. Now we're going to talk about telehealth documentation. During the public health emergency, Patient consent may be verbal for commercial and Medicare payers. Review your payer guidelines for post-PHE requirements, including whether telehealth consent must be written or may be given verbally. Telehealth services should follow the same documentation requirements that are required for in-person care, with the following addition. The patient consent, remember, telehealth consents are different than a consent to treat, and verbal consents are permitted during the public health emergency, but New York State does require some additional information to be documented, and I've provided that link. You should record the method of telehealth delivery, whether it is audio only or if it was furnished via audio and video. This will also help your compliance team or your auditing team determine whether the appropriate modifier was appended based on how you delivered or furnished that telehealth service. The vendor information, the location of provider and the location of the patient, any other participants that may be present during the visit, total time spent, including non-direct time, and it's recommended whether a provider personally observed vitals or if the vitals were patient reported. And the reason for that is there's many quality reports that actually disallow patient reported or remote patient monitoring vitals. So you want to be sure that you have a way to capture that information in your EHR in the progress note or SOAP note. And your EHR can be customized to support the documentation requirements for the provider. You can add a visit dropdown of telehealth that says telehealth audio versus telehealth audio and video. And then based on that selection, you can include radio buttons that has the FQ modifier for audio only, have a 95 modifier, any other payer specific modifiers that may need to be appended to those services. You can add phrases, that automatically insert in a progress note that prompts a provider to say, where's the location of the provider, the location of the patient, the method of delivery and such. So you can meet the requirement needs by customizing some of the templates in your EHR. And this would be an easy lift and would lessen the burden of your providers when making sure that they're documenting all those required components of that visit. For New York State Medicaid, post the public health emergency, all patients and prospective patients must have at least one in-person evaluation session with clinical staff prior to participation in telepractice. If found suitable for telepractice, the patient or prospective patient must execute a statement of informed consent prior to receiving services via telemedicine. This evaluation for suitability for telepractice may be the same day as the first telepractice session. So that's important. The practitioner shall confirm the member's identity and provide the member with the basic information about the services that he or she will be receiving via telehealth. Written consent by the member is not required. Telehealth sessions or services shall not be recorded without the member's consent. And then for additional consents, you should take a look at the New York State Early Intervention Program consent for the use of telehealth. And for mental health, informed consent must contain a benefits and risk statement when providing remote services. Next, we're going to talk about documenting telehealth E&M codes. Document office visits as you normally would under 2021 E&M code guidelines, with the exception of the standard telehealth documentation on the left, with the check marks, the patient consent, again, the mode of telehealth delivery, location of provider, location of patient, any participants that may be present, total time spent, whether provider personally observed vitals or if the vitals were recommended. And for teaching, same for the teaching physicians, all the same documentation is required when you're precepting. Telehealth service delivery does not change coding selection. That's important. When you select your E&M codes, there's no difference. You code them the same way again, and then you would leave the modifiers in place of service up to your billing department. Modifiers for telehealth only represent the technology used and it changes often. Each payer is requiring either a place of service of 02 or a place of service of 10 during the public health emergency. Some payers are even saying, hey, let's leave it to the place of service that normally would have been had that service been furnished on site or for in-person care. There is a link provided on the resource slide that has up-to-date payer guidelines on modifiers and place of service. For FQHC and RHC telehealth billing, For private payers, it's important to remember that your billing team stays up to date with all commercial, Medicare, and Medicaid changes. And then you want to follow the checks, right? You've got the appropriate licensing, coverage, documentation, and coding. And then you want to make sure that the place of service code that you're selecting, payer specific, is appropriate, and then the appropriate modifier. For New York State Medicaid, you want to use 95 for telehealth, and GQ for store and forward technology, and GQ for RN services 99211. And then again, we have the most recent Medicaid update for New York State, and they also want you to use place of service 02 until further notice. Another important thing, specific, is that specific to our FQHCs and RHCs, is that there is no specialized billing for private payers. FQHCs and RHCs follow the same payer rules and guidelines for all private payers as non-FQHC and RHCs do. So any other private entity or organization, we bill the same exact way. Only Medicaid and Medicare plans have FQHC and RHC specialized billing. An important modifier that was effective January 1 of 2022 is the FQ modifier for Medicare, and that is for behavioral health audio only. So that is in effect. It was implemented. It was in effect January 1st of 2022, but was implemented on 4/1/2022. For FQHC telehealth specific billing, during the public health emergency, FQHCs can bill as a distant site provider and can also bill the originating site fee with the Q3014 CPT code and 078 revenue code. All services listed on CMS lists of covered telehealth services may be provided by an FQHC. This includes FQHC core services and non-core services. FQHCs will bill the G20025 for all FQHC services and non-FQHC services. That's with no service lines underneath, except for mental health and sub-services beginning 1/1/2022. Beginning this year, January 1 of 2022, FQHCs can be reimbursed their normal PPS rate for all mental health services and substance use disorder services furnished via telehealth, including audio only. So that's the only true payment parity that FQHCs and RHCs, which is basically the same. We'll talk a little bit more about that on the next slide. The only time that we're going to receive payment parity for our services is when delivered via telehealth, is when those services are for mental health or substance use disorders. Modifier CS is still required for COVID-19 related visits, and that will be paid at 100%. So it's a cost waiver for patients. They won't have their co-insurance or co-payment. Modifier 95 is optional after 7/1/2020. So with the implementation of that G2025, a modifier was no longer necessary, as the G2025 determines that this is a telehealth encounter. Date of service 1/1/2022. Again, for mental health and SUD, bill your PPSG code G0469 and G0470 and the service line, so each additional service line, with a 95 or FQ modifier for audio only. And that modifier, again, would be for dates of service 1/1/2022 and after. Post the public health emergency, FQHCs and RHCs will still be able to bill for mental health and substance use disorders furnished via telehealth. But all other medical services, it will take actually an act of Congress to allow FQHCs or RHCs to be distant site providers. So again, they're waiving that distant site rule for mental health and SUD services post the public health emergency. For New York State Medicaid, there was a lot of information. So there's two pathways, right? If you're an FQHC that's opting into the APG model, and if you're an FQHC who is opting out of the APG model, I've provided a link at the end of this series that you can click on that will actually go further into how New York State Medicaid during the public health emergency, how you're supposed to bill your claims as an RHC or an FQHC. Keep in mind that post public health emergency right now, essentially, until you hear further notice. Until further notice, this will be the regulatory guidelines in place. Post public health emergency, again, they just reference this 2020, it came out in 2020, this guide, and it was later updated, I think, in 2022. There are not many changes with New York as far as telling us what's coming up the pike post the public health emergency. For RHC specific telehealth billing guidelines, very similar to FQHCs, during the public health emergency, all medical services are billed with a single line HCPCS of G2025 after 1/1/2020. For mental health and substance use disorder visits delivered via telehealth, you will bill the appropriate PPS code of G0469 and G0470 with the service line and a modifier 95, CG, modifier 95 and CG for audio and video, or modifier FQ for audio only. So just to clarify, you would bill as you normally would previous to the public health emergency, except that you would add your 95 modifier or an FQ modifier for audio only. Post the public health emergencies, FQHCs and RHCs will continue to deliver telehealth services for mental health and substance use disorder. Please click on the resource page, the link on the resource page for more information regarding billing these services post the public health emergency. And then remember, unless there's an act of Congress to allow FQHCs and RHCs to become distant site providers for medical services, FQHCs and RHCs will only be reimbursed for the originating site fee with the CPT code Q3014 for all non-mental health and substance use disorder services delivered or furnished via telehealth. For New York State Medicaid, same thing as FQHCs. There's two tracks, the APG model, and then when an RHC is opted out of the APG model. And again, there's a link at the end of this resource that will provide you additional details and resources on how to bill those claims. Telehealth reimbursement. Reimbursement for telehealth is changing frequently. Some insurance payers have ended their payment parity for certain services like telephonic E&M codes. Some payers have ended the waiving of co-payments and co-insurance. For specifics around New York State Medicaid, click on the link provided in the resource page of this presentation. For up-to-date commercial telehealth reimbursement policies and coverage, click on the private payer billing link located on the resource page of this document. During the public health emergency, Medicare will reimburse all services furnished via telehealth for medical visits billed with the G2025 at $97.24. And then mental health and SUD services will be reimbursed at the normal FQHC RHC rate. In the 2022-2023 enacted Medicaid budget, payment parity is in place for all Medicaid and commercial payers. And the link is right here, and it's also provided, I believe, at the end of this document. Next, we're going to talk about communication technology-based services. Just to confuse us even more, the verbiage around telecommunication services have changed. What was once called virtual communication services, or VCS, has now been expanded and is included under the umbrella of CTBS, communication technology-based services. Not all remote services are considered telehealth, according to most commercial and Medicare payers. These services do not require specialized billing, such as the use of modifiers and place of service code 2 or 10. It is important to review each payer guidelines for payer-specific requirements during the public health emergency. Including in the CTBS category are telephone E&M services, online digital E&M services, virtual communication services, and remote patient services. And we're going to go into each service category a bit further. It's important to educate your providers on the difference between telephone E&M codes and audio-only office visits. Telephone E&M codes are meant to be triage calls and must be patient-initiated. Audio-only office visits replace an in-person visit and meet the required 2021 E&M coding guidelines. New York State allows audio-only E&M codes, replacing in-person visits. That is the code set of 99202 through 99205 and 99212 through 99215. Certain payers allow audio-only E&M codes during the public health emergency, and a few commercial payers have added audio-only telehealth permanently under certain conditions. Example, the patient must be established and an in-person visit must occur within 12 months. Next, we're going to talk about online digital E&M services. These codes are for the use when E&M services are performed through a HIPAA-compliant secure platform. These are for patient-initiated communications and may be billed by clinicians who may independently bill E&M services. They may not be used for work done by clinical staff or for clinicians who do not have E&M services in their scope of practice. During the public health emergency, the established patient rule has been waived. Next, we're going to talk about virtual communication services. Again, to confuse us a little bit more, the nomenclature has changed. Some payers are now referring to virtual communication services as CTBS, communication technology-based services. And you may have noticed that the G2012 and the G2252 overlap with CPT codes 99441 and 99443 telephonic E&M codes, as these brief interactions have the same definition when being performed telephonically. Verbal consent must be obtained, and the service is initiated by the patient, and global rules apply. New York State Medicaid covers remote patient monitoring. Check out the link provided on the resource page of this presentation for more information. For FQHCs and RHCs billing Medicare, remote patient monitoring is not a covered service. For FQHCs and RHC virtual communication billing and reimbursement during the public health emergency, RHCs and FQHCs should bill CPT code G2012 that are delivered telephonically with the G2025. VCS holds the same definition as the 99441, 99443 code set for telephonic E&M codes. Reimbursement will be $97.24 instead of the $23.88. So if you read the AMA's definition of G2012, and then you read the AMA's definition of the telephone E&M codes, they have the same global requirements. They both require patient initiation. It has the same 7-day previous rule and 24 rule, except during the public health emergency where we're going to be reimbursed additionally. Remote patient monitoring is not covered for FQHCs or RHCs, and online digital E&M codes have now been included under virtual communication services, so that CPT codes 99421 through 99423, FQHCs and RHCs can bill a G0071 and be reimbursed an additional $23.88 in addition to any other qualifying visit. This can be billed alone or in addition to a qualified visit. Consent may be given at the same time you initially provide the service during the public health emergency. Post the public health emergency, G2010 and G2012 is rolled up and billed to G0071. That means it doesn't matter which code you bill, the G2010 or the G2012, you're still going for FQHCs and RHCs, you'll roll it up to that G0071. Medicare waives the RHC and FQHC face-to-face requirements for virtual communication services. You can only bill for these services when the medical decision or remote evaluation is for a condition not related. Again, that's 7-day previous, 24-hour next day. Virtual communication services are meant to be triage services to determine whether a visit is needed or not. Beyond the basics. During the public health emergency, many of us had to pivot quickly. We soon learned that with a rapid implementation of telehealth, we were forgetting about the services that were offered to our patient during in-person care. The outreach team no longer was down the hall, and the front desk staff weren't handing out depression and food insecurity check-ins, screenings during check-ins. Some quality measures were declining as providers lost the elements of team-based care during the initial telehealth rollout phase. This is when we realized that more than ever, it was important to bring back social care into our healthcare settings. Telehealth can decrease social determinants of health by addressing transportation barriers, childcare barriers, and patients with limited mobility. We continue to innovate the use of technology by meeting the demands of our patient population and community. We found that our enrollment team and outreach workers were often finding more success in assisting our patients with eligibility and enrollment via technology. They were able to control a patient's screen during the session. So you can log on to the marketplace and you can drive their screen for them. Also, if we were helping, if our staff was helping to sign up for Medicaid programs, um, or determine financial eligibility at local hospitals or what have you, and they forgot their tax documents, or they could go, when they're at their home, they can just go to their office, grab that. So it really did reduce the number of times a patient had to come back to give us additional information because they had it right there, right in their home. So that was super convenient for both the patient and for our team. Our school-based health counselors, they were no longer seeing patients at the school during the public health emergency, particularly when the schools were shutting down. So our LCSWs and our LCPCs and our LADCs, they began calling campaigns, reaching out to all of our patients that were due for screenings, such as social determinants of health, depression screenings, audit screenings, DAST screenings, and who could better triage a PHQ-9 and provide a brief intervention or link our patients with community resources than our social workers. And when our schedule opened, we expanded our social care efforts, particularly during a time that patients were more isolated than ever. And this is a time when linking medical and non-medical services help providers meet their bottom line and meet the needs of their patient population, all while increasing quality of care. I've included 2 resource pages. One is generalized New York Medicaid federal policy, the Medicare fee schedule and such. And then the second resource page is FQHC and RHC specific. This is the link that includes, these links will include everything that was discussed during this presentation. And then also, if you have any questions or would like to reach out for additional support, please send me an email and reference this presentation, and I'll be sure to get back to you. The Northeast Telehealth Resource Center provides continued technical support around all things telehealth, and this includes telehealth billing and coding, and those questions will be routed to me.